Don't say
Welcome,
sir,
Dr.
please.
Kumada. Welcome.
I am
Yes, sir.
Srinivasan.
Good evening. Good
No,
evening,
sir.
sir.
So thanks for giving me this opportunity as a webinar to attend from USA.
Yeah. Giridhar, how are you?
Yes, sir. Good evening, sir. Good evening, everyone.
Good evening,
Srinivasan, sir. Good
Giridhar.
evening, sir.
Good
Nice to
good
see
evening,
you in
good
the
evening,
group,
good evening.
sir.
Yeah, yeah,
Good evening,
yeah.
Naveen, sir.
It is my pleasure
Karthik,
because
sir. Good evening,
it is
ma'am.
a boon that it's an this thing been webinar. So immediately, yeah, good, nice.
Thank you, sir. Thanks for joining, sir. I'll just
Thank you,
change my
thank you.
name in
I
the
must thank
group.
you. Yeah.
I think we'll just wait for 5 more minutes, sir, and let the central NF people join. Once they are all in, I think we can start, sir. We'll just take 5 minutes, 5 more minutes.
Good evening, Dr. Mangala Bharati.
Hello, sir. Good evening, sir. How are you, sir?
Good evening, good evening.
Giridhar, I'm unable to open my video.
Hi, Manoj.
Yes, sir.
I'm unable to
Hello,
open
Girdhar.
video.
Hello, sir. Hello, Ajit, sir. And video, sir.
Yeah. By any chance, have you given the
No,
topic?
I'm not able to see you also. Can you just log out and log in, sir?
I'll do that.
Probably something from your end, sir. It could be that.
Okay, I'll just log in again.
We have some difficulty
evening.
with it now, sir.
Good evening,
Good evening,
everyone.
sir.
Good evening, all of you.
I don't think Manoj sir has joined or Amit has joined. We'll just wait for 2 more minutes, and otherwise I'll call them. Once they are in, I will start the program, sir.
Good evening, Dr. Dadich.
Good evening, sir.
Good evening, sir.
Hello, Giridhar. I think now it's.
Yeah, now we are clear, sir. Now your audio is also, it's perfect, sir.
Thank
Voice
you.
is also clear.
Thank you. Srinivas sir, good evening.
Good evening, all of you. So all stalwarts are there. I'm very happy that I'm able
It's
to
good
attend
to see
from such
all
a
senior
long
faculty
distance.
Karthik sir is
Yes,
there.
so many
Ramarao
eminent
sir,
people
good
are
evening.
there.
Good evening, sir.
Good evening.
Hello.
Ajit sir, you're loud and audible, sir. I think I'll call up. I don't see Manoj sir here inside. I'll just call him up and find out whether he's there. Manoj sir, are you there?
Pradeep sir, good evening.
Good evening, sir.
Good evening.
How are you, sir? Ramarao sir, good evening.
Good evening, sir. Good evening, Pradeep sir.
How are you, sir?
I'm very well, sir. What are you?
I'm doing good, sir. Thank you,
Ramana
sir.
sir, good evening.
Good evening, sir. Suresh Garu.
Manoj is joining.
Good evening, Dr. Amro.
Karthik sir, good evening.
Hi, thank you for everyone for joining. Actually, looks as if I messaged Manoj and Amit in the group, but I think they are not responding. I think in between they can join. We should not wait. Anyway, I'm representing NNF anyway. So, yeah, I'm sure Amit just messaged that he's just waiting to join. Amit Upadhyay is going to join 2 minutes.
Yes, sir. Yes, sir. Please, sir. Yeah.
Whatever Manas sir, let me call him.
Yeah, I've called him, sir. I think I've sent him the invite again. I think he doesn't have the invitation. He's not able to find the invite. I've sent him again, sir.
Okay. Great.
Yes, I think you should send the invite, Giridhar. They don't seem to have this invite.
Yes, sir. I think they might have actually misplaced it somewhere. 1 minute. I'll send to both of them now.
I have joined this.
So Amit sir has joined. Okay.
Welcome,
Good evening to
Amit.
all.
Hello, sir. Good
Good evening,
evening.
sir. Dr.
Welcome,
Karthik
welcome.
Dadich.
Hi,
Yeah,
Amit.
welcome.
Hi,
Yeah.
Dr. Ajit. How are you?
Good.
Hi, Ami sir.
Hello, everybody. Hi,
Hi, Ami sir.
Dr. Rama.
Uh,
How are you? Hello,
Very
ma'am.
well, sir.
Good evening.
Hello.
So nice to see
Hello,
you.
good evening.
Dr. Kumtagar.
Good evening, ma'am.
Wonderful color of your sari, ma'am.
Good evening. Good evening.
Very good evening.
Dr. Giridhar, Manoj sir is just
Hello
joining.
everyone.
Yes, sir.
Good evening.
Good evening,
Sorry,
sir. Good
sorry.
evening, sir.
Hello. Very
Hello,
good
good evening.
So, shall we start the program?
Yeah,
Welcome,
please.
Manoj. Welcome.
I'm so
Yeah.
sorry, I was not getting the link. That's why.
Hi,
Yeah, yeah. I
Manoj.
just sent the link on the group. But anyway,
Yeah.
thank you for joining. I was just
Thank you, thank
wondering.
you.
Yeah.
Manoj is back home, huh? Soon today.
Are you feeling okay, Manoj, now?
I'm better. I'm better. Okay, sir. I'm good.
Thank you. Thanks.
Hello, Dr. Manoj.
Hi,
Hi,
Nalini.
Hi,
How
Dr.
are you?
Patricia.
Fine.
hello, sir.
Shall we start the program?
Yes,
Nice to
yes,
see
we
you
can
all.
start. We can start.
Yeah. So, good evening, everyone, and a warm welcome to you all today. We have a gathering of neonatal luminaries in this platform. So, I am Dr. Giridhar, and it's my pleasure to have you all here tonight. On behalf of the National Neonatology Forum of India, I am honored to share some exciting news with you. The Neonatal Online Education and Learning Program, abbreviated as NOEL, is one of the flagship programs of the National Neonatology Forum. This program is aimed at imparting clinical expertise and skill among neonatologists with particular focus on trainees in neonatology, especially the fellows, thereby helping them in acing their exams well. As we enter the fifth year of this program, we are pleased to launch the new academic session, the details of which I'll be sharing a bit later in this webinar. So without wasting much time, I would like to invite our Honorable President of the National Neonatology Forum of India, Dr. V.C. Manoj sir, to address the gathering. Over to you, sir.
Thank you, Giridhar. Hello everyone. Warm greetings from National Neonatology Forum. Respected teachers and my dear friends. It is indeed a honor for National Neonatology Forum to continue this legendary series, NOEL, which was, those of you remember, was started by the previous president, Dr. Ranjan Pejawa, during his time when we had and started depending on online education as a means when during the pandemic. So now, since then, NOEL has caught on, and now it has become one of the modes of teaching our fellows. NOEL has also evolved over the period in the last few years, and now this year we are happy to present a new format which the chairman of the committee, Dr. Giridhar, would be explaining in detail, where we would encourage more discussion of the fellows in the platform. And once that sort of interaction takes place, we would be taking their how much the feedback in the form of post test and things like that, so that like how much of learning has actually gone in. We hope that this format will be more useful for the fellows and those who prepare for any neonatology exam. So I would not want to waste more time on this. So welcome all of you to NOEL, and I thank all the seniors and teachers of neonatology who have joined today. And from now onwards, we will have a galaxy of teachers, and the fellows get to hear the various aspects from the various teachers, and that's how the teaching is going to be. We start with the normal newborn, and then we will evolve. So this is the first in the series of the weekly teaching series called NOEL. Welcome all of you to NOEL. Thank you. Over to you.
Yeah, thank you, sir. Thanks for those inspiring words. It was good to know about the origin of the NOEL program. I think the program is evolving, and thanks to the previous team who had done an exemplary job in bringing forward this mode of teaching. So, next I would like to invite our honorary General Secretary, Dr. Amit Upadhyay, to say a few words, sir. Over to you, sir.
Good evening, everybody. Hello, and Dr. Giridhar, you have created a wonderful program. The format is old, but the concept is old, but The format is new now, and it is wonderful to see so many panel discussion on such a pertinent topic by uh, doyens of neonatology who are experts in their field. I'm sure both nurses and fellows will gain tremendously from this. So, nothing to keep the fellows and nurses away from the academics tonight. And over to you, Dr. Girdhar, again, to please introduce the speakers and initiate the program. Thank you.
Uh, Sir, just before we do the introduction of the speaker, I'll just like to talk a little bit about our team and what we plan to do over the next year. So we know that change is the only constant thing in life, and a new team has taken over from the fantastic outgoing team. And the team which has set very high standards of teaching and has been well received by everyone, including the fellows and other trainees. So our new NOEL team, thanks to the opportunity given by the National NNF, is a blend of new and very experienced people also. And we are blessed to have received the services of Dr. Nalini Kant, who continues to serve as our advisor. Welcome, sir. Dr. Arjit, he'll be our co-chairperson of this committee. Dr. Akash will be the coordinator, and Dr. Somashri will be the joint coordinator of the committee. So our young and exciting team members, most of them are there in this platform currently, include Dr. Samir Sheikh, Dr. Gopal Agarwal, Dr. Abhishek, Dr. Binesh, Dr. Sangamitra, Dr. Sai Kiran, Dr. Janisha, Dr. Gunjana, Dr. Dheeraj, Dr. Jatin Mistry, and Dr. Vimlesh Shoni. So if I missed anyone, I'm sorry, but I think you're all there in this program, because our list is quite long. I'm not able to trace out your names. So welcome all. And these are going to be our start of our activities for this year. And our team will be coordinating this activities of this program. So what we have done is we had a deliberation among ourselves, and we have come up with a new program blueprint. So I'll just share just what we are planning to do in the subsequent next 1 year. So okay. So I think, hope my screen is visible. So what we thought was we divided each month into different specialities in neonatology, dedicated to different specialities in neonatology. So since our program is catering to a wide variety of audience, including trainees, when practitioners can benefit, nurses can benefit from this program, we thought that we'll start with a very basic thing, but which has a lot of different layers to it. That is general neonatology. So we every month there may be 4 or 5 weeks. Week 1 will be having a panel discussion, and we are starting this panel discussion now. Week 2 will be on case presentation by the fellows, and there will be a discussion on this. And week 3, faculty will be giving a case-based lecture, and another faculty will be doing a practical demo. And week 4, because that is going to be questionnaire for the people who watch the videos. So there'll be a discussion by the people who have made this questionnaire, which will be part of the week 4 activities. And the week 5, if it is bound to be there in a particular month, I think we will decide as necessary. So in addition to that, there will be 4 new pre-recorded video lectures on that monthly specialty, which will be available for viewing on the DigiNNF platform. So this platform, I think most of you would have had an opportunity to go into this platform. For people who have not had an opportunity to view this platform, it is freely available. You can Google up DigiNNF and see. So you can enter this website and you can register yourself. And at this point of time, registration is open for all the NNF members. So in this platform, we have the different programs have been uploaded, and one of this program is thing is going to be NOEL. So here different lectures will be available for viewing, and these lectures will be periodically upgraded also. So the more important thing is, since this program is focused on the fellowship trainees, so they are expected to view these lectures and complete the self-evaluation questionnaire by the month end. And this questionnaire will be reaching us, And whether there'll be an evaluation of them based on this questionnaire, or we'll give their feedback to the respective centers. And as you all know, because this program has been envisaged for the fellowship trainees, so attendance of all trainees who are currently undergoing training of NNF fellowship is mandatory. So this is these are the videos which are currently uploaded on the DigiNNF platform, and this is there for everyone to watch. And also there is another, area, as Dr. VC Manoj sir had mentioned. I think discussions related to the talks, and we'll be encouraging more discussions on this platform, because a lot of times we see that the fellows don't, come up with questions during the live lectures, but subsequently there might be more questions which will, once they view the lecture, or after some point of time, they can free to post their questions on this NOEL discussion group, and which will be answered by the corresponding experts. So this is what we plan to do in the next year. And so I'll just unshare my screen. So every new initiative, it requires a very promising start. Since it is IPL is a flavor, I think in cricketing parlance, a promising start requires the right people to give us a start. And at this point of time, in this particular platform, we have the right people to give us this start. So I would like to invite my teacher, Professor Dr. Kumuda ma'am. Madam requires no introduction to most of the attendees here, and she is my teacher and a teacher to many of the attendees here also. Welcome, ma'am. Our esteemed panelists also, who are going to sit on the panel discussion with ma'am, also require no introduction at all. It's my privilege to have Naveen sir, Dr. Pradeep sir, Dr. Mangalabharati, and Dr. Sai Sunil Kishore as a fellow panelists for this panel discussion. This topic is a seemingly innocuous topic, but it has very different layers to that. And it is very interesting to know what is the perception of the very prominent neonatologists. So topic is going to be care of the normal newborn. And I would like to hand over to Poona ma'am to lead the discussion. So before we start the discussion, the attendees, kindly mute yourself. The host also can take the lead and start muting the attendees who unmute themselves, because it could be of disturbance to the presenters. And they are also requested not to annotate on the screen, because that will also be a disturbance to them. And before we start the panel discussion, I think since we have around 117 participants now, can everyone open their videos? We can have a group photograph. Yeah, thank you. It's all done. So let's, without wasting much time, we'll hand over to Kumuda ma'am to run the proceedings. Over to you, ma'am.
Thank you, Dr. Giri. Good evening to one and all. All the respected teachers here and President and Honorary General Secretary of NNF. And I'm very happy to be the reopening of our NOEL learning session. And we are going to have the topic of care of the normal neonate. And for this panel discussion, we have 4 speakers. And as Dr. Giri said, Dr. Naveen Jain is the Senior Consultant Neonatology Department, KIMS Hospital. And we have Dr. Pradeep, who is HOD of the Department of Neonatology, MS Ramaya Medical College. And Dr. Sai Sunil Kishore, he's from Visakhapatnam. He's a senior consultant. And again, Dr. Mangalabharati, HOD Professor, Institute of Obstetrics and Gynecology. To open this topic, we know that all newborns born is a happy event for all the family and the whole world. But excellent care or high quality care are we rendering to all the newborns, which is very, very essential for the newborn health, we do have still a lot of questions to be answered. And we have divided this topic into 4 sessions because we do know that maximum death occurs on day 1. And if at all the rest of the death occurs within the first week, and the rest in the rest of the neonatal period. So, a high quality essential newborn care is a right of every newborn, and they have the right to breathe normally and to be very warm and also to be fed with the right nutrition. And also, we should understand that this newborn care is not only meted out in the facility, but it needs to be also rendered at home. This is one area as of now we are weak, which we have to do. And also, it should span through the neonatal period. Does not mean that care is only when the baby is at the facility. So, to do this topic in 4 sessions, we have Dr. Mangala Bharati to open the session with care of the newborn soon after birth. And the second session, which would be taking care of the baby beyond birth, that is after the first hour of life, would be Dr. Sai Kishore. And also for giving support for breastfeeding would be dealt by Dr. Pradeep. And discharge screening and discharge advice would be done by Dr. Naveen J. So, without wasting my time, I would request Dr. Mangala Bharati to open the session with care soon after birth. Over to Dr. Mangala Bharati.
Thank you, ma'am. Good evening, everyone. Thanks for the opportunity to NNF, and congratulations to NNF and the new and young and energetic NOEL team. And again, it's always a privilege and pleasure to be on a panel with my esteemed teacher, Professor Kumuda ma'am, and my sincere regards to all the co-panelists also. So let's just... Ma'am, is my screen visible, ma'am?
Yeah, your screen is visible. Your voice
Yes,
is also...
your screen is visible.
Okay.
Voice also audible.
Audible.
You can proceed.
Okay. Thank you, ma'am. So it has been already said that a care of a normal newborn is a very inequitous topic. I'll say this topic is more about, this is not a topic where we just try to research a lot or try to look for more evidences or more change in practices. You all will agree that this is a very, very crucial topic in terms of the quality of services provided. So here we know a lot about actually what needs to be done. But the big question in the care of a normal newborn is that, so does every newborn labeled as a normal delivered in our country receives the optimal required quality of care? That seems to be the big challenge. And so healthy newborns requirements, to my mind, are very quite simple. So all that they need is warmth, food, love, and time and space to adapt to the new environment. So it is not at all necessary to complicate it. So one more thing is that, it may be easy to categorize abnormalities into various systems and domains. But categorizing the care of a normal newborn, I think, is, even though ma'am has tried her best to classify it into 4 different stages, I'm pretty sure there will be an overlap of certain topics among the 4 of us. And I have, I think I am lucky that I am the opening batsman, but still I'll try to avoid stepping into the postnatal domains, whatever happens beyond the delivery room as far as possible. So when I talk about so giving a quality and optimal care to a baby, so without any troubles, I think it's more about so these domains. Let's start with something like, okay, even though the baby is normal, so how do we ensure that this baby is a normal? So every pregnant mother who just walks into the delivery room, we need to quickly just go through her background and the history in detail to ensure that there are no risk factors, there are no surprises. and the baby doesn't get into any trouble. That's what is the risk assessment is all about. And even if you label a baby, we are expecting a normal newborn. We all know the importance of being prepared to face the challenges, because even if there are no risk factors, we know a small percentage of the so-called normal pregnancies, these babies can get into trouble because a lot of adaptation happens at the time of birth. So that is why all bodies, including NNF, everyone, we keep on emphasizing the importance of being prepared for emergency resuscitation of, even if there are no risk factors. We know the percentages, a small percentage, around 1% might require some form of resuscitation. I'm not going into that. That's itself is a different topic. So that's our domain that we need to be careful. We need to be trained and prepared for. Once the baby is delivered, to just aid in the process of adaptation, what we are supposed to focus on. So obviously the thermal support, because delivery room is an area where still a significant proportion of babies, various studies pointing out in various numbers. So hypothermia in the delivery room still seems to be a problem that is happening in our country. So thermal support, and of course, the importance of the placental transfusion, ensuring that placental transfusion happens, initiating skin-to-skin contact, leading to early initiation of breastfeeding. So these are the core domains. Of course, the moment these things are done, we will just shift our focus to giving care of certain important things in the delivery room, like what do we do about the skin care, eye care, and umbilical cord care. Again, as I said upfront, I'll be restricting my discussion only to the delivery room. I won't be talking about skin care beyond the delivery room. And even if everything is normal, as I said, it's every family would like to get an assurance that things are all right. Everybody wants a hale and healthy baby. So it is the responsibility of the person who is attending the delivery to do a detailed head-to-foot examination using a structured tool to just screen for anomalies. Even in today's era, where actually the antenatal diagnosis with the wonderful ultrasounds has improved to a great extent, we do see pick up some anomalies which are either difficult to pick up in fetal screening or are missed in a fetal screening. That does happen. So a structured head-to-foot examination is essential. And we need to talk a little bit about vitamin K immunization and support for family. So I'll just quickly run through, as I said already, see, I'll just show you an usual story. Though I think even though we know that this should not be the sequence of events, this is a story which we keep happening in our delivery rooms most of the time. We know that obstetricians, if it is especially a well baby, still there is a significant amount of immediate cord clamping happening. And the baby is, the moment the baby is separate from the mother, the baby is received onto an, so we are more comfortable in examining the baby under a warmer, more controlled environment and examining there. That's the next step. Of course, once we receive, we suction the mouth and nose. We know IM comes before N. And we proceed to drying the baby well. And there are centers who, again, once the cord is cut, we prefer to apply an antiseptic like an betadine over the umbilical cord. And as a part of examination, we check the patencies of the nose, esophagus, and the anus. And still people are fond of giving a stomach wash, especially if the licorice meconium stained. And this people don't seem to like these ugly looking babies. Babies are beautiful, but people think that this vernix makes them ugly. So we use oil and a good amount of wiping, removing this vernix. There are certain centers who prefer bathing the baby also soon after birth for a cosmetic touch. And unfortunately, for some time, there are still centers we come across who just put on some time. The adaptation might get better if we put the baby on a little bit of oxygen for some time. So that is, again, most of you would have realized that we don't need a big amount of evidence to say the wrong things, what are happening in what the scenario, what we have witnessed just now. So as far as the normal newborn carrier is concerned, evidence-based care in normal newborn it doesn't mean only knowing what to do. Most importantly, it means knowing what not to do. So that is why I think you all will be aware of the Lakshya program, the Labor Room Quality Improvement Initiative. A lot of focus on ensuring that things happen as expected or as prescribed, and we are not harming the baby in any way. So ensuring delivering the baby over the mother's abdomen, not separating the baby from the mother, so that we initiate an early skin-to-skin contact. And this concept of receiving the babies under a warmer is now reserved only for sick and small babies. It should never be done for a healthy baby. And of course, to facilitate this process, there is a big role for birth companions. So involvement of the family in this stage has to be ensured. We all know how much the presence of an experienced family member who had undergone this process helps the mother in going through this process. And no more is a routine suctioning of the oral cavity or the nose recommended unless we feel that the airway is blocked in some way. This can lead to vagal stimulation and more destabilization. And not only a vagal stimulation, people have looked into what happens to the oxygenation of these babies over a period of time, those who have been routinely suctioned versus those who have not suctioned. Enough to say at the moment, if you do routine suctioning, it leads to poor oxygenation. It takes more time for the baby to achieve better oxygenation. So that's why even people are, if necessary, just go with wiping. That's good enough. Even if you want to do some secretions are there. So even if secretions are there, think about wiping rather than suctioning. And so it's mandatory to wait for a minimum period of at least a minute for the placental transfusion to happen. In rare situations, if that is not possible, at least request the obstetrician to do a milking of the umbilical cord in babies. We're talking about normal babies, so we can do that, no problem. And the patency check, again, this is an area, even though we have been doing this for quite a long time, you can restrict this only to situations like if there is an abnormality of the liquor, like a polyhydramnios or oligohydramnios. If it is a small for gestation age baby, or any baby who is having some respiratory distress. So these are the babies where it may be mandatory to do the patency checks. Otherwise, if a baby is normal, no liquor abnormalities, not an SGA, the yield of this is very, very low. There is hardly any need to do the routine patency check because this procedure may introduce not only it causes pain, it may be a source of an infection. The same holds true for stomach wash. No more a routine stomach wash is recommended. The vernix is a fantastic thing. It protects the integrity of the skin, maintains the moisture. So please keep the vernix. It will get absorbed automatically over a period of time. So these things will do more harm trying to clean the vernix with oil or bathing the baby. Of course, again, we know that vitamin K1 is the preferred one. We all know the dose 1 milligrams in babies more than 1,000 grams of a birth weight. But we need to have a mechanism of giving hepatitis B because we in our institution, we prefer to ensure that a baby receives hepatitis B as per the norms in the first 24 hours, which is again indicated in the Lakshya program also. We prefer to give hepatitis B in the delivery room itself for well babies. You may just give it 1 or 2 hours also. It is more of a logistic thing, but we need to ensure hepatitis B is given the first 24 hours. Oxygen may be more dangerous. Just 2 or 3 more points to touch upon. I think as far as there's again a lot of cord collections happening, I think we should try to promote public cord blood banking. Individual one is optional. And the importance of breast crawl. There is a separate topic on breastfeeding. I'm just passing on. This is what WHO and certain bodies do recommend application of especially something like chlorhexidine for care of umbilical cord, whereas the NN of CPG is very clear. It is enough if you just keep the cord dry. There's no need to apply any antiseptic. There is a conditional recommendation. So chlorhexidine has been found to be beneficial if the incidence of, in special situations like the incidence of sepsis is quite high and the mortality is quite high. A rough guideline is that if your NMR is more than 30 per 1,000 live births, in those situations, consider applying chlorhexidine to the umbilical cord. Otherwise, just a dry care is good enough. we know the nappy, we have started using it a lot. So it interferes with the drying of the umbilicus. We need to know how to use the nappy, keep the nappy folded in care of a normal newborn. And the same for eye care, even though certain bodies recommend routine antibiotic drops or ointments. So as per the NNF recommendation, CPG, again, I'll say just cleaning from inward to outward, use two different clean, moist cotton to clean the eyes, no need for antibiotic drops. The skincare, I will leave to the postnatal team. I'll just see some of the tools that we use in our institution. So one thing is that, as I said, you need to have a structured tool to just document all these things. Documentation is very, very important in the delivery room. Again, a mandatory part of Lakshya. So just the various steps what we discuss. Again, I'm not going through the details. Especially for Abgar and all, we had a lot of discrepancies when people just write Abgas just like that. It's always beneficial both for training and for quality to have the components of Abgar listed clearly and ask people to score for each and every component so that we ensure the quality and it trains the people are also a lot. The head to foot examination, you need to have a structured sheet where things get documented. Of course, the plan during follow-up, handing over to the subsequent wards. We have a good MNCU, where it goes, how it goes, the transport also will come in. I think it will be taken by subsequent speakers. To some extent, even though we see babies, these three are the common problems which we want to screen even the so-called well babies at the time of birth. The three common problems we face are hypoglycemia, sepsis, and jaundice in a well baby. So it's good to identify the risk factors at the time of birth. We use a structured chart where people score the presence or absence of risk factors for these parameters. I think some of you can make use of it. In the head to foot examination, one thing which is commonly missed, even we don't do it that much, is the eye examination, especially the red reflex. We know the limitations. Maybe I think Dr. Sai Sunil is going to talk on that. All that I just wanted to point out is that we do now have new tools which are available, handy tools, apart from the conventional ophthalmoscope, which are very, very easy to use to examine the red reflex. And even some smartphone-based tools are coming up. I think I'll stop here and I'll just wait for the others to contribute more. I think if there are questions, I'll take it up later. Thanks for the opportunity again. Over to you, ma'am.
Thank you, Dr. Mangalabharati. And only few points I wanted to stress. When we say early skin-to-skin contact delivery onto abdomen, even Lakshya recommends it. Now we are promoting for all the healthy newborn infants at least 1 hour in the labor, not to be disturbed for anything during that first 1 hour, including vitamin K, weighing, and immunization. All that should come after the first golden hour. The first golden minute for assessment of breathing, and the first golden hour is only for skin to skin contact and early initiation of breastfeeding soon after birth. So that is and zero separation. You very well brought out the warmer. Everyone puts a baby in the warmer, leave the baby in skin to skin contact in the labor bed itself with the mother. But for that, for monitoring in crowded hospitals, we need to allow the birth companion to be present along with the mother if the baby has to be kept in skin to skin contact for 1 hour. And again, this unpleasant experience of oral suction and injections in the first hour goes a long way in producing negative influence in the brain networking. So that is one thing which we have to do. And of course, other points here correctly and very beautifully expressed with good illustrations. And again, regarding chlorhexidine, as you said, it's only in settings where there will be a lot of infection or bad practices where they apply something else like cow dung or something where they promote a chlorhexidine, especially the WHO in context specific recommendation. Thank you. I think we will move the questions we would take in the last because already it is 8:30. We will move to the next speaker, Dr. Sai Kishore, for care beyond birth, that is beyond the labor room care. Sir, can you start the program?
Ma'am, am I audible, ma'am?
Yeah, you're audible, sir.
And the screen is visible, ma'am?
Screen is visible, but you have to open the PowerPoint.
Is it visible now, ma'am?
No, no, sir. No, sir.
Okay,
We can
Sunil,
see
can
some
you
screen.
unshare and reshare again? Better actually.
Well, you can open PPT and then share.
Yeah, you unshare. Now open the PPT and reshare again.
Yeah, I have closed that. So
Click on unshare. That share again. First, open in your computer, sir. Open the PPT.
yeah, I'm just doing that, ma'am.
While he is opening, also there was a point raised by Dr. Dadich regarding the temperature of the operation theatre. Especially keeping it very low is again a important factor which also increases the chance of hypothermia. That should be taken care of. Room temperature of the delivery room and operation theatre. Yes, your screen is visible, sir.
Visible, ma'am. Thank you.
Yeah.
So, very good evening, and thank you very much for the opportunity. The audience are like fellowship students, and I'm sure actually it's easy for you to manage a case of severe case of HMD, intubate, ventilate, giving surfactant. But I think it's much more difficult to handle a normal neonate. So, Girdhar has wisely has proposed this topic, care of normal neonate. So, I'm going to discuss the second aspect after initial care at birth, that's in the postnatal ward. So after the first 1 hour, like golden hour management, which is mainly targeting your like after initial resuscitation, it is skin to skin contact, roaming in, and establishing breastfeeding. So after that, like all your other things will come. So here you have to administer vitamin K. So 1 mg for babies who are more than 1.5 kilo and 0.5 mg for babies who are less than 1 kilo. So initial vaccination, BCG, polio, hepatitis B, you have to give. And the first examination and assessment will come here. So in the first few hours, so it is a head to toe examination. And again, temperature recording has to be done in the first 1 hour, which is again a QA indicator for any hospital. And you have to look at all the vital parameters and examine all the pulses, including femorals. So one should not miss examination of femorals here after the initial stabilization of the baby, and do anthropometry of the baby and gestational age assessment of the baby, and always look carefully for the birth injuries. So one can easily miss things like clavicular fracture, humerus fractures, those kind of things. So be careful and look for the subtle, even subtle things also, and as well as midline defects. And here another thing, like once you do the initial resuscitation, once you do your anthropometry, the thing here is like you have to identify whether the baby is well or unwell, or that baby is at risk baby. So identifying at risk baby and unwell baby is more important here in the first few hours. So, well, baby, like the baby will be having all these things: normal vitals, color, tone, activity, normal feeding, passing urine and meconium in the first 24 hours. But yeah, a sick baby, like it's sometimes actually very, for the beginners, it's difficult to pick up the subtle signs. So it can be as subtle as weak suck reflex, or it can be very obvious as like severe cyanosis, which is responsive to which is unresponsive to oxygen. But another thing is like you have to also target at-risk babies. That means actually the baby who is otherwise looking normal at that particular point of time, but who is at greater risk of developing problems in the subsequent next few hours to few days of life. So you have preterm babies, you have low birth weight babies, and any presence of risk factors like in the gestational diabetes, hypertension, or baby who is at risk of sepsis like PRM more than 18 hours. So these kind of things, and if there's any fatal bradycardia or things like abnormal Dopplers. So these are all the babies who are at risk of babies whom we are anticipating problems in these babies really. So what is the care in the first 24 hours? So care of the card, it was partially discussed by Dr. Mangala Bharati. So basically it is the dry card care which is important. So you need not apply any antiseptic solutions there unless there is like neonatal mortality in the particular area, geographical area is more than very high. Like in that situation you can use chlorhexidine, but most of the time actually it is the dry card care which is important, and the nappy is also diaper also has to be kept below the umbilical cord stump. And second thing like oil massage. So whether you can apply oil or not. So it is generally if recommended to apply oil, but the kind of oils which you can use are like safflower oil or coconut oil. And bathing is always, it should be avoided for the first 24 to 48 hours. So WHO recommendation is minimum like you have to avoid in the first 24 hours and preferably after 48 hours. And avoiding some traditional dangerous practices like applying any kajal, surma, as well as the things like cow dung, those kind of things are to be strictly avoided, which you have to emphasize to the family. Now coming to the after initial care, coming to the question of screening. So here actually you have to target certain screens. So I'm not going to discuss the discharge screening like hearing screening as well as pre-discharge bilirubin screening. Those things I'll skip for the next speaker. But the things which are important for the postnatal period, those are the things which I'm going to discuss. So you have to assess the sepsis risk in that particular baby. And in some cases, you need to do cord blood screening, glucose screening, and pulse oximetry screening, and newborn metabolic screening, including thyroid screen and bilirubin screen. See, regarding sepsis screen, like we know that actually, like if there are any maternal risk factors for sepsis, or if the baby is symptomatic, which are specific for sepsis, actually, like here there are different scoring systems which are available. Like in India, you have different sepsis scores which are published from PGI as well as AIMS. And this is one of the famous Kaiser scale, where actually it is a kind of early onset sepsis risk calculator. Basically, like whatever sepsis scores you are using, basically they look at the maternal risk factors as well as the symptoms of the baby. In this particular thing, actually it is based on the GBS status, which is not specifically applicable for us. But the idea is actually here you have to avoid over use of antibiotics, and we should not miss any baby with sepsis. So that is the idea of all these sepsis calculators or sepsis scores. And the second thing is like though pre-discharge bilirubin screening, botanist nomograms, I'm not discussing. So in the first 24 hours for jaundice assessment, what is important is like you have to identify at-risk babies for jaundice, like who can develop significant hyperbilirubinemia or pathological jaundice. Many times actually, like we see though jaundice is a very common problem actually, and every one of us, we know how to manage babies with jaundice. Many times what happens in the postnatal wards, some of the high risk babies, at risk babies are missed and they'll end up with oxygen transfusion or bilirubin encephalopathy. So it is important to identify these risk factors, ABO, RH incompatibility, and previous baby with jaundice, if the breastfeeding is not established, anything like cephalohematoma, bruising, use of maternal oxytocin. So these are some of the risk factors for developing significant jaundice. And the red flags being, so jaundice in the first 24 hours. And if you have any palms and soles staining, like bilirubin almost going up to 18 to 20, and the baby who is at risk of bilirubin encephalopathy, any risk factors for encephalopathy, like coexisting perinatal depression or sepsis like that, or if there is any high colored urine and pale stool. So these are some of the red flags we know for jaundice. So now coming on to the pulse oximetry screening, which is very important for you guys. So this is the objective is basically for screening critical congenital heart disease. It's not for all CHDs. So for early picking up of critical congenital heart diseases. So what is the time it should be done? Like we have to do at around 24 hours. So 24 to 36 hours is the like rough timeline. So most of us prefer to do at 24 hours of baby's life. So you have to look at the both preductal as well as postductal saturation values. So this is the algorithm, but the thing basically is like the both preductal as well as postductal saturation should be above 95%. So that means actually it is normal, and the difference between preductal and postductal should be less than 3%. So if that is there, so that fits in this green box, so which is normal. Whereas like if the saturation either in preductal or postductal is less than 90, that is abnormal. So that straight away like that baby needs proper pediatric echo by pediatric cardiologist and proper evaluation. And you have this yellow box, which means it is borderline. So if the saturation is coming between 90 to 95, or if the actual difference, preductal postductal difference is more than 3%, so that qualifies for borderline, and you have to repeat within 1 hour, and again repeat within 1 hour, and you go accordingly. Like if it still continues, you have to do proper cardiological evaluation. So metabolic screen, again, like you have to give information to the family and the parents regarding the importance of this metabolic screening. So it is a filter paper test. So you have to give the information regarding what are the different available things available disease, like what are the disease it can detect, and you have different panels for that, like common panel, 7-panel testing, and you give the option of detailed panel so that actually the family can choose which metabolic test they want. And many times actually in the postnatal wards, what happens is like the previous two which I was just discussing is like metabolic screen to pick up inborn error of metabolism, and the previous pulse oximetry screening. These two are basically very important. And many times it also happens that in the postnatal ward, we see babies suddenly they collapse, sudden deterioration. So like whenever there's any sudden deterioration, you have to keep your mind open, and these are the things which you need to suspect: inborn errors, doctors dependent cardiac lesions, and sometimes it can be even endocrine emergency like congenital adrenal hyperplasia. So coming to some of the other red flags as well as the things which you need to see in the postnatal wards are like failure to pass meconium in the first 24 hours of phase. So delayed passage indicates either it's a Hirschsprung or meconium plug, or it can be a surgical, any other surgical cause. And examination of the hip is again very important. You have two methods, ortolani as well as Barlow's, to exclude your DDH. And in newborn examination pertaining specifically to Moros, so normally the Moros is well established by 36 weeks, and hung up Moros in the setting of like a very high jaundice, it indicates early stages of bilirubin encephalopathy. And absent are like incomplete Moros or asymmetric Moros, it can be due to brachial plexus injury or fractured clavicle or infantile hemiplegia. So again, looking at the red reflex is very important. So now there are so many things which are available, including even smartphone tools also. So this is, I think, the last slide, which indicates quality indicators in postnatal care. Being fellowship students, like you all should know, like what should be the best possible postnatal care in your setting, and what are the quality indicators which are available, which will tell about the optimal postnatal care. For example, these are some of the dashboard indicators or quality indicators, like what are the percentage of babies exclusively breastfed at discharge, and the time to first temperature record. As I was mentioning, it should be done within first 1 hour of life, and percentage of the babies screened for congenital heart disease as well as hearing, and readmissions audit. So all these things are very important as quality indicator tools. So basically, like as pediatricians and neonatologists, our proactive role ensures early detection and prevention of the problems, and it will improve the quality of overall care of these neonates. So thank you very much, and I'm happy to take any queries.
Thank you, Dr. Sai. This is very, very important area of care because most of the babies, once transferred from delivery room, postnatal rounds do not happen. In fact, the takeover from by the postnatal nurse, which she should be well trained to support the mother to keep the baby warm. Second, to support breastfeeding during this period. That's a crucial time where breastfeeding support has to be given, and also identify danger signs, not only by the postnatal nurse. Maybe we have to teach a little bit, at least on the second or the third day, to the relatives and the mother to identify, especially the ones like not feeding well, passage of meconium and passage of urine, such simple things like difficulty in breathing. Those things also have to be taught. The main crux of the problem is postnatal rounds or examination every day, at least once, is not happening across the country in most of the hospitals, especially where they have lot of delivery room. That is number one. And number two also, like the second thing, and I really am happy, I think even Dr. Naveen would bring out this. Eye examination is one thing which gets missed in the postnatal. And we later on come to know that this child has got congenital cataract or other problems, eye problems, where which has to be attended immediately. So that is also another thing I wanted to say in this. And I think most of the rest of the things Dr. Sai has covered. So we will move to the very, very crucial, important step in postnatal care, not only in the hospital but also at home, that is supporting breastfeeding and seeing that a woman is confident from by the time she is ready to go home with her feeding, and the baby and the mother dyad are happy and comfortable in breastfeeding. So I invite Dr. Pradeep to handle the session on supporting breastfeeding during hospital and also at home.
Thank you, ma'am, and thank you, Giridhar and Inanna, for inviting me. This is the topic somehow very close to my heart, and I will agree why it's so important. I will start sharing the slides. Yeah. My slides are visible, ma'am?
Yes, yes, sir.
Yeah, yeah.
Yeah.
Why it is so important to support the mothers for breastfeeding? Now, you'll be surprised if you look at the global rate of breastfeeding is only 36%, and even in our country recently, the data says they're very proud that it went from 46% to some 57 or 58% of exclusive breastfeeding for babies less than 6 months. Now, I fail to understand something which does not involve any money, does not involve any technology. We are unable to achieve 100% exclusive breastfeeding rate in mothers. Just we are talking about exclusive breastfeeding till 6 months. I think there are two major reasons why we have not been able to do something as simple as getting the mothers to exclusive breastfeed. Absolutely no money involved, no technology involved. We invest a lot. I remember our obstetric HOD, Dr. Sarla Gopal, used to scold us as BM resident, saying that you break your head so much with a 10 to 28 weeker who has 60-70% chances of survival, who has no chance, less chances of being intact, and there is an healthy term baby who's in the postnatal ward, and you do not want to care for these babies. And one simple intervention that has shown to reduce mortality in these babies with absolutely zero cost is just getting these mothers to breastfeed these babies exclusively. Only two reasons: ignorance and not information on the mother side. And the second important system is failure of the healthcare system in supporting these mothers for breastfeeding. Now, I'm here to just highlight what do you mean by support to the mother for breastfeeding. Now, this is the definition I got. Support to the mother for breastfeeding includes practical, emotional, and informational help to initiate and maintain successful breastfeeding. See, there are three things I have told very, very clearly here. Exclusive breastfeeding support does not mean putting banners and posters in your postnatal ward and telling mother, oh, you should breastfeed the babies. Everybody does this job. But do you practically help support the mother? Do you emotionally support the mother? Do you help the mother to initiate? And do you help the mother to maintain successful breastfeeding? Now, this whole gamble is called as supporting and not just putting banners in your postnatal ward. So we are very good at giving the education and information. We are very, very poor at practical help. We are very, very poor at emotional support. We might be very good at seeing some technical medical support as such. So I'll go over one other after the other. Education and information. As I said, we are very, very good at giving information. We sit there and give a big lecture saying that, oh, you should breastfeed the baby. Breastfeeding is very good for your baby. Nothing else should be given. Breastfeeding, bottle feeding is bad. As I said, so we are very good at doing this education and information. But is this enough to get the mother have a successful initiation and exclusive breastfeeding? My answer would be no. This is just a part of it. There's no doubt that we need to give information. We need to explain the benefits of the breastfeeding to the mother and what is the benefits for the baby, giving some posters to teach latch and position, guidance, and hazards of formula and bottle feeding. I think this part all of us do very well. Whenever we are in the hospital, we put banners, posters, and we have pamphlets being circulated in the postnatal ward. But I would say this is only a part of it. And what is more important is the emotional support and the practical support. When I say emotional support to the mother, what it means is encouraging and reassuring the mother. Remember, every mother needs constant encouragement and reassuring. It is not enough just to come and say, oh, you breastfeed the baby. That's not called as emotional support. Listening to her without judgment. I think this is very, very important. Half the time, we do not have patience to listen to what mother is saying. I mean, I'm not surprised when we go out for rounds and mother is trying to say, whole night my baby did not sleep. I did not. No, it's okay. You breastfeed. Everything will be okay. No, it's fine. You just feed everything. You'll have enough milk. Sir, I felt my baby. I do not have enough milk. No, man, you feed. It's okay. And this is what we say, listening without judgment. You just don't have the patience to sit and listen to mother, tell me, why do you feel so? Being empathetic. I think somewhere we are losing that being empathetic to the mothers. Remember, one person in the postnatal ward or in the hospital who needs a lot of empathy is the mothers who has just delivered, who's going through a lot of postpartum blues, lot of apprehension, anxiety, and with this social media, I think this anxiety and apprehension is much more higher. Building confidence and reducing the stress. I think this is very, very important if you want this mother to continue successful breastfeeding. Now, emotional support, when in the postnatal ward, this is the common scenario. The senior consultant with all the juniors going for the rounds, shouting at the postgraduates, shouting at the residents. And you cannot give any kind of emotional support. More than reducing the stress, I think you will be the source of stress for the mother who's very scared now to talk to you after the kind of blastings you have done on your postgraduates or residents. I think this is a very, very common scene that you see in the postnatal. Now, I'm saying this is the most important step if you want your mothers to have successful help. Practical help. What do you mean by practical help? Which I'm sure most of us are failing in our duty by helping mothers to get comfortable during the feeding, observing a feed and giving a feedback. Honestly, if I ask how many of us actually stand there, observe the mother feeding, how many are able to give a good feedback to the mother? Oh, good, you are doing a good job. No, there is a little bit of position issues. There's little bit of, we are not doing that. Managing lactation problems. She has flat nipples. She has inadvertent. She has some concerns. She's going through some anxiety. We have one standard answer. Don't worry, just feed the baby. No, we need to stand there and solve this life. I think this practical help is where I feel we are failing miserably. As seniors, we are not able to impart this knowledge to our junior residents, and they are not able to do the same in the postnatal. Now, what I mean by practical help is, it is impossible if you are in a busy unit with 20 babies in the postnatal ward to go around and assessing every mother's breastfeeding and trying to give a practical help. So what it means is you create a full-fledged support system in the hospital which can help the mother or help the mother to successfully lactate. Now, the system which we have in our place, or which I would suggest that most of you have, is there should be a three-tier system. There should be the first person who's in contact with the mother is the postnatal ward nurse and the residents who can take rounds every day, pick up if there are any problems. Then comes the lactation nurse, whose only job in the hospital is to visit all the mothers, sit with the mothers, observe the breastfeeding, give a feedback, solve their lactation issues research. And then comes your consultant in charge. I think we are somewhere down the road. Our pyramid is inverted, where I think the consultant role is very, very minimal. You need to have your postnatal ward nurses, residents, and the lactation nurse. One thing which I always insist or what we have started doing in our hospital is using latch score to assess breastfeeding objectively. Now, if I ask patient how the mother is feeding, the mother is feeding very well. Now, what is very well for this resident may not be actually the truth. And 3 days later, you have this mother with engorged breast or the baby coming shifting to the NICU with hypernatemic dehydration. And I call the resident.
Sir, you have muted your. Sir, you have muted your phone. Please unmute yourself.
No, somebody muted me. Okay. I'm audible now?
Yes, you are audible now, sir.
Yeah. So I think using latch score as an objective assessment of breastfeeding is very, very important. It gives a lot of objectivity and not just say mother was feeding very well. We know this latch score. There are scores which is say 0, 1, 2. Any score of less than 8 there is a feeding problem. More than 8, you say the mother is doing a good job. Latch score. So what we have started doing is the nurse in the postnatal ward assesses latch score every day. Any mother who has a latch score of less than 8, she informs the lactation nurse. We have started to put this sticker onto the case file saying that lactational support is needed for this mother. So this is some kind of a system where you are trying to screen all the mothers for lactation problems, identifying the mothers who have lactation problems, and then the lactational nurse will sit with the mother trying to address her issues. What are the concerns and issues? So this kind of 3-tier system where a regular nurse is able to identify, pick up the mothers, put a case and put a file saying that this mother is a high-risk mother or needs lactational support, and then the lactation nurse coming into the picture has helped us to get these breastfeeding problems quite at a decreased rate, and we have been able to achieve a good breastfeeding rates. The last thing I would suggest is the social support system. We are very happy with providing maternity. Now, remember that maternity is 6 months, and many a times if mother starts applying leave 1 month or 2 months before the delivery, their maternity leave, including my own nurses, they'll have difficulty in getting that 6 months of maternity leave even after the delivery. It's a whole thing covered 6 months. So I think some kind of a system, like I say, work accommodation for mothers and our own healthcare workers, our own nurses, my own residents, doctors have difficulty in continuing exclusive breastfeeding because they have to report to the duty early. They are put on night duty. A simple change is like giving them some time off to visit the babies for breastfeeding. And thanks to COVID, I think a lot of mothers are now having work from home options. So we tell the mother, if there's an option, why don't you opt for work for home and continue with exclusive breastfeeding? My own nurses, we help them by giving them, avoiding some night shifts, giving them some comfortable work where they can visit the babies for breastfeeding. So some kind of a support system, even after the mothers are going home, we need to continue to provide a good amount of social support and kind of work accommodations if she's a working mother, which is a very, very common issues we are facing in Bangalore. And one of the things they start saying is, doctor, I have to go to work anyhow after 5 months. I do not want to breastfeed. Can I start with formula feed quite early? I think that is one of the apprehensions they have got. And I think giving that kind of a social support system is very, very reassuring to continue exclusive breastfeeding. So my key messages are, every mother needs support for lactation. Let us not be under the impression that, oh, mother is fine. Oh, she is gravida 2, she is gravida 3. No, every mother, irrespective of her gravida, irrespective of her socioeconomic system, needs some kind of support for lactation. Giving information without any practical or emotional support will not help the mothers. I think this is the point I want to take, everybody to take home, that just giving some information, giving a lecture on exclusive breastfeeding and benefits will not help if you do not support the mother practically and emotionally. Establishing a good lactation support system is important in the hospital, in your nursing homes, in your hospital. If you want to achieve 100% exclusive breastfeeding targets, I'm not happy with 59, 57%. I think our target should be 100%. Thank you.
Thank you, Dr. Pradeep. Actually, as he said, that practical help of initiation of breastfeeding should commence from the labor room and should be continued in the postnatal ward. And not only should we empower the mother, but also empower one person who's going to be there with the mother. And objective assessment should be part of all the postnatal assessment of breastfeeding. And again, we have to train our nurses to offer practical help. We most of the time train them to give knowledge, but practical help is what is required. I think we have to concentrate, and this is only the tip of iceberg in the facility. Once they go home, totally they don't have any support. And we should also look at social support, which is supposed to be given by the government and other things. I will post those questions at the last. So thank you, sir. We move to Dr. Naveen J. I think he's going to be the last batsman who's going to hit sixes for all six balls here. Dr. Naveen Jain, for your discharge advice and discharge screening, please.
Thank you, ma'am. And I agree with the madam's statement that there are going to be six sixers. There are 140 attendees in this meeting. And each hospital, my hospital is about 150 to 180 deliveries in a month. And only 10 or 12 of these inborn babies go to your favorite ICU. 160 babies are in the ward. But to be very honest, out of my 6 consultants, I enjoy doing postnatal rounds. Some of them don't mind if I push them there. And most of my residents, as they grow in seniority from first year to second year to third year, find it humiliating to go and do normal baby rounds. And if you are a share investor, I don't know where you will invest in. You will invest in 10 rupees or in 150 rupees. Don't mistake me for the kind of examples I'm giving. But some of my colleagues who presented earlier also were
बोला ना.
speaking about normal newborn care.
हो.
And they were how normal newborn tends to slip into abnormal newborns. But normal means normal. And there is a lot to be given to a normal newborn. Although madam is going to speak about home care after this, what we need to understand that if a mother came to deliver in a hospital and she does not have pregnancy-induced hypertension, gestational diabetes, twins, prematurity, and she has a normal weight baby, then also she has to be meted care from us. Otherwise, don't ask for your consultation fees. So I will touch upon in the next 2 slides only actually some of the aspects which may sound medically important, but more important than that, a little bit more on what is literally what some of you would think is general practice or normal newborn. Now, even though hearing screening was discussed in the previous, or at least touched upon, what we need to know is, are we telling the mother or the family what are we doing in hearing screening? So, 2 aspects need to be told. 10% of babies who undergo hearing screen may have one or the other ears retest. The mothers get worried that this baby is having hearing impairment. We need to sit there. It takes only 30 seconds to sit down and draw an ear canal and show her that the sound has gone to the cochlea, coming back to your machine. And if the ear canal is very tiny, there is some secretion, this may not happen. We know this that 10% of babies who undergo a hearing screening may have a retest, and that's why it's not called fail. It does not mean that your baby is having hearing impairment. But this reassurance should not set them off from any botheration. I suggest that if there is a vaccination book, whether it is a MCP card or a beautiful vaccination book of a private hospital like mine, on the 6 weeks vaccination area, not the discharge summary. Nobody looks at the discharge summary when the baby comes back, especially if it's a normal newborn. On the 6 weeks area, you make a circle and say OAE to be reassessed or hearing to be reassessed. Explain to the mother that this hearing test is going to be done where? In my hospital, I write it is on the main building, it is on the 2nd floor, it is in room number 228. This is where audiology lab is. You will not be charged. The test report will be available immediately. Professor And our greatest Dr. Kalam used to talk about something called diagnostic pain. The minute I get an abdominal pain, my worry is not abdominal pain. My worry is I have to go to hospital, I stand in a queue, then I will get a test, then a report will come, doctor would have gone home, next day I will get the test, again I have to go there. So don't add to diagnostic pain if OE is a retest. If you educate the family why the hearing test was done and that it is so important for child's language development, you would not require any apps or reminders. You would not require doing testing. So in the first part, we are doing hearing testing. Please make it effective. If after hearing testing, more than 10% mothers become more worried and don't sleep for 6 weeks that the baby is having hearing impairment, then we have done injustice to normal newborn care. If they have a retest, they should go home with a clear explanation that the baby is not hearing impaired. On the same time, if you have tested somebody and if the baby is retest and they don't come back after 6 weeks and do a retest, believe me, you could go to jail. Ensuring compliance when they come to follow up is your responsibility if you have done a screening test. If you have found a value which is not okay, it is our job. I won't go on red reflex, but I can only tell you so much. We have been teaching in red reflex for last 20 years as teachers. We have been asking this in exam and being sarcastic to candidates who have not done it. But 4 babies we have missed, who are all VIPs, film actors, politicians, and so on, like Umuda madam said, who had a white reflex picked up by the parents after going home. And coming back to us on 4th, 5th day, some had a persistent vitreous, some had a cataract, some had a retinoblastoma. So it is not impossible or difficult to do. We tend to pass on in our outpatient service. My colleagues make my life difficult because they will write and tell the family, today I could not do red reflex, a baby didn't open the eye. Tomorrow, day after tomorrow, when you're seen by somebody, please ask for it. So when the parents come inside, in the OPD itself, they will start saying, doctor, eye checkup is not over. So please make sure that whatever you're planning to do, a technology way would be to have an app which the hospital and the parents share. And on the app, your checkpoints for normal care are there. You tick, and the parents should be able to see that you've done it, and this is the report, and this is the action. But that is, of course, maybe DGNNF should do it later on. When it comes to thyroid screening, one of the most effective screening program in the last 50 years because of 2 reasons. Number one, if you don't do the test, and don't pick it up, you're damaging a baby with a curable condition. Number 2, if you pick it up, treatment is affordable even in the lowest part of India. It is so complete and currently without any adverse events. And therefore, I think interpreting a thyroid report is that everyone's doing the test because it is so easy and blood is taken. But please make sure when you're writing a discharge summary and sending a baby home, you check that if you're doing only TSH, what is the value? Less than free T4, what is the value? Or T4, what is the value? And even when they come for the first 6 weeks vaccination, please make an effort for 1 more minute going back to the record and checking whether thyroid screening was done. It should be ideally done and checked before leaving the hospital. We do it in-house, so we have the report in 4 hours. If you're using a filter paper, it may take some time, but make sure that there is a closing the loop pathway on TSH. If TSH is more than 10 to 20, then some of our hospitals like ours retest again. We do pick up a few people with delayed rights, TSH and hypothyroidism. We do 17-hydroxyprogesterone for picking up CAH. It is far rarer. We might have picked up one in last 10 years through the screening program, more through the disease presentation from outbounds. And this is the incidence, about 1 in 10,000, whereas thyroid is about 1 in 5,500 to 3,000, depending on the kind of population. Now, important one is about, again, bilirubin, a part which requires both a pre-discharge value, and I would urge every one of you to understand the bilirubin nomogram by Dr. Bhutani. It's a very simple concept that if today's value is high, tomorrow's also might be high. This is called tracking. So if you understand that all we are treating when we're treating hyperbilirubinemia with phototherapy is we are treating babies with 95th centile of bilirubin for that age. So if it is at the 95th centile before discharge, then the predictive ability is very high. It doesn't mean that babies who have value less than 95th centile can't go up. The lactation could have gone bad. They might have an hematoma. They may have a genetic mechanism where they can't metabolize bilirubin. So they may have a previous baby giving a history, a vacuum extraction where the clot may be only inside the skull and not outside, and GDM baby or a low birth weight baby not feeding properly. So if you have a high value, you inform the family. Tell them, this is helping me to know that you need to be seen tomorrow or don't go home. And if you are not able to come back to my hospital because you are staying far away, you please make a separate chit and say, pre-discharge bilirubin was high, go tomorrow at this date, this time before the OPD of your next doctor closes and have a done check. Saturation I'm skipping because Sai has covered it. I would like to re-emphasize one part of lat score because I think it's never repeated wastefully what Pradeep ji said. In the last score, the last part of C and H is the critical part, is the comfort and the hold. Sometimes I enter the room of a mother and she is actually holding the baby with one hand and feeding like this, and other hand she is doing a video call or WhatsApping somebody. This is perfect comfort and hold. She is an expert. She's a pro. Even if you miss screen time and all those things, but she is able to do it. Sometimes you enter the room and a grandmother is holding the baby and a nurse is holding the grandmother and they are trying to support the baby who is feeding. Here, both comfort and hold are very bad. So even if you can't do the full latch score, at least make sure the baby is being correctly held and the mother is comfortable, and check the weight loss before discharge. It should not be more than 10% of birth weight. Like every one of my colleagues emphasized, do check there may be some additional medical risk factors. A whole antenatal scan has been done. They have found renal pelvis dilatation. You also forgot, the gynecologist also forgot. And after 4 months, they come back and ask, oh, doctor, we forgot to ask, what about that RPD, which was 20 millimeter on one side? By now, you have missed all the good work that is done. Forget the legal aspect. Medically, we have missed the whole part of science. So if there is something deviant, slightly different, then please note that down and make sure it is done. Now, before discharge of a baby, the mother crafting is an important part. Preparing the mother to go home, she is leaving your hospital, she is going to be at the mercy of grandmothers who might have been grandmothers very long ago. Nuclear families where only a husband who is having Google only to help, or no help at all, with everyone being busy and she being alone. So, discharging advice includes a need to check jaundice very specifically. Jaundice is not a disease, but jaundice can become a disease. I prefer to show them a video which, if it is in danger zone, and all the students who are in this, I'm going to post a message called as PICK. Please see the video. It's called Parents and Infants of Children with Kernicterus. Go to this site. There is an opening video on this. If you see this video, you will cry and it's a challenge. None of you will stop seeing the video without crying. And after that, never in your life you will miss and allow kernicterus to happen to baby. It says, my baby was born normal. That is the first work it says. So don't allow any baby to get kernicterus. Educate the family why they need. They can't come on 10th day and say, doctor, you told me about jaundice, I forgot. Now I have come for assessment. The boat is already gone. Talk to them about next immunization. Tell them which date, where to come. Please do not condemn government-sponsored immunization programs and say private programs are giving better immunization. Both are good quality vaccines. You can tell them without any bias what are the small differences in the program parents can choose. Most of my pediatric residents who deliver, gynecology residents who deliver, are a complete mess when they come with their own baby. And this is the proof of our poor training that if a pediatrician cannot take care of his own baby, imagine how he can take care of others' baby with normal variations. They come back and cry about rashes. They label milk stools as diarrhea. A milk stool is a stool which is watery, buttermilk-like, comes with a blast, is stinky in smell. And how many babies are getting stool routine tested for lactose intolerance and getting antibiotics, low lactose milks for this purpose. It might look like a GP presentation, but normal newborn is normal newborn. And we need to remember that we are missing simple things like this. Telling them that third day milk has to change the color of the stool from green, black, green to yellow. Rashes that appear on the face, on the upper chest, these many of them are just estrogen withdrawals. Please do not apply anything. You do not have to give a moisturizer just to satisfy a family, a steroid cream which will suppress it immediately, an antibiotic cream. Don't do this. Have the courage to say that nothing is required. Let those patients who require bad treatment go to some other doctor. Choose those 40-50% who are seeking a doctor who says there is no medicine required. Care of umbilicus, again, small bleeding stump, so many babies get one more vitamin K. Please understand that the first dose of vitamin K given in hospital itself is supra pharmacological dose, about 5 to 10 times the dose that baby needs to get. And therefore, be very careful. Giving a second dose of vitamin K is not casual and not harmless. Applying antibiotics to a yellow discharging umbilicus. Yellow is the way necrosis of the umbilical cord tissue has to happen for it to separate. It was holding the whole baby to the mother for 9 months. It can't just break free in one day. So neutrophils have to go and break, and this necrotic tissue is yellow. So unless the periumbilical area is red and angry, please do not use any antibiotic. Tell them not to cover the area with a diaper. It will cause granulation formation. Traditional practices, please, all are not bad. So NNF had a document long back. I can't find it easily now. Good practices, harmless practices, and harmful practices. You may have to lead and see. So everything that the parents do is not bad if it is tradition. Many traditions have a lot of value. But at least those which are bad, like applying something into the nostril and oil. We have had babies coming with status epilepticus after getting some oil for a URI and such medications. Danger signs, some of the danger signs which are printed in many of the WHO and NNF guidelines, to an educated society and to a Kerala-like society, they do critical us. Come back if your baby has seizures, come back if he's blue, come back if he's not moving. But these are also there, but subtle danger signs also need to be told that a baby would normally wake up in 4 hours and feed. If he doesn't, just wonder if there is something going different. Or not passing stool for a day or two might happen, but not passing urine for a long duration needs to be paid attention to. Common emergencies, you must tell them how to manage. This can be an excessively crying baby. It can be a red looking area in the vaginal area, which is vaginal bleeding, which is physiological, and some real emergencies where baby tends to choke during feeding. And the last, we have walked into an area where we all are sitting and listening to each other. We are using teleconsultations. We are using our WhatsApps to communicate. Why not for the families? So telehealth is the way forward. Just for clearing doubts of a normal baby care, a parent need not have to walk to a busy hospital, stand in the queue, get a viral bronchiolitis and go back. Travel for 40-50 kilometers in a taxi and bust their money. So the way forward is teleconsultation. We have started an initiative for last 6 months where 10th day of discharge, we are giving a teleconsultation complimentary to the family without they asking for it. And we have realized that two benefits are there. One, many times they were going to other hospitals or other practitioners who are not even pediatricians for asking advice on many things. They would land up getting an amoxicillin 1/4. They would get a topical application. And by addressing their questions at home, we are able to reduce their over medication doses. And second, fantastic improvement in continuation of lactation support is happening. We are able to answer the lactation queries and this would go on. So thank you for your attention. This can go on. I would only appeal that the change we could make is that for the first time, the Cloharty, which was meant to be an intensive care manual, had a chapter on normal newborn care. And therefore, please read that. And I would urge NNF to have a normal newborn to be placed in the examination. Then only we will have importance to this subject. Thank you for allowing me to speak.
Thank you, Dr. Nabi. Actually, I don't have anything else to add to your thing. As expected, you hit all the 36 runs which were supposed to be given. Only one other point I wanted to add was Like as we are discharging after all the advices, we should never forget to tell them that they have to take a baby who will understand, comprehend, and have everything touch, smell, senses. So we have to tell them that. And also early learning activity, that is what even WHO is now recommending, what is called as a responsive care, like a responsive feeding. We have to give them responsive care where they have to interact. So we have to tell the family, as you said, most of the mothers are now with the mobile all the time in the postnatal ward when they come to us for consultation, everywhere, even in the labor bed, they are with the mobile all the time. So we have to tell them that they have to disconnect themselves from the mobiles and connect with the baby uh, with good eye to eye contact, and of course speaking and all that. That is also very important when we discharge them. So I have now most of the things what we said was in the facility. So the newborn period extends up to 28 days, and most of the normal newborns are going to stay at home. What are we going to do? So I'm going to ask each one of you, what is your plan for home care, and what do you do in your hospital setting? At least now all our 147 fellows, when they graduate and go, they arrange something for their postnatal care at home. At home. So can I start with Naveen now? You said already it's an excellent initiative that you got a free teleconsultation on 10th day, so that you have continuity. But anywhere home based newborn care recommends 7 postnatal visits, home visits, and WHO says at least 4 postnatal visits at home should be needed for looking at how the baby is kept warm, breastfeeding is maintained, and whether the baby and the mother are doing well, and also to identify danger signs and other things, and especially jaundice. If mothers are discharged within 24 to 48 hours, then they can have significant severe jaundice, which could also cause bilirubin induced toxicity. So what are your plans, each one of you, if you could and respond quickly? I think we can wrap up with the key points.
And thank you for allowing me to be the first one. Uh, is I think we have to utilize one power which many other countries don't have, is the power of a mother or mother-in-law available at home. And many of them are constructive, many of them are not. So converting them into constructive grandparents before going home and in home care when they come for follow-up includes only one skill, is letting that young woman and a young man to know that these people are experienced and they have more knowledge in taking care of a baby than I as a pediatrician have. You praise them and they will be suddenly listening to you. They will agree with everything you say. Otherwise, they will go out of the chamber and say, doctor is saying this. This is all English in the book. Reality is not this. Listen to me. Many times mothers and grandmothers say, milk is not enough. I plead to them and say, one word if you just change and tell the mother, milk will come tomorrow. She will be a
Yeah.
champion. Thank you for your support. Or I tell her, before the
Yeah,
mother would
this
ask about
this
Kajal,
support is needed for continuing exclusive breastfeeding at home for 6 months. Okay, I'll move to Dr. Sai. Thanks, Dr. Naveen.
yes,
Are you there, Dr. Sai? If he's not there, can I
Hello?
request Dr. Pradeep?
Yeah, Sai is there. Sai,
Yeah, yeah, we should empower the family for like taking care of the babies like at home. So one thing is like they should understand all the danger signs, because all the mishaps like which can occur. So if they don't have enough knowledge, like we don't educate them, so like they can again come back with like sick baby or sudden problem. So we should empower them, and we should explain the danger signs for the family.
Dr. Pradeep, please.
yeah, I think my postnatal at the care at home basically involves, one is again going on and on with saying about breastfeeding. I do call them little frequent follow-up. Sometimes we do share our our hospital mobile numbers with the patients to pose some of these common issues that they have to make things convenient for them. But I do like to see them basically on third day, fifth day for assessing of jaundice if they have been discharged. But even after that, I call them after a week or two just to reassure, because getting that weight checked and telling the mother, and I always put it in lighter note, said you have scored 10 out of 10 on breastfeeding, you've done a fantastic job, and the baby has gained weight. And I can see that the confidence of the mother boosts up so much, and that constant reassurance, because all these mothers are always worried, am I doing my job right? So I think they just need that constant reassurance, you're doing a fantastic job. And I think one objective way of assessing lactation and giving them that certificate saying you're doing a good job is a good postnatal weight. And I agree with Dr. Praveen and Sai saying that you do explain them about danger signs. And within first week, yes, we need to ensure coming back about we do only transcutaneous bilirubin, so that makes them less apprehensive to come to the hospital for jaundice. Because many of the parents are reluctant to come to the hospital for jaundice assessment because they feel they're going to prick the baby. So we do it by transcutaneous bilirubin, and that has helped a lot of mothers to keep coming and saying, doctor, check again, maybe my jaundice is still there. So they are now more than happy to come. Otherwise, earlier we were seeing a lot of reluctance in these parents to come back to the hospital. I think that's one point. I think if nobody has touched, transcutaneous bilirubin at the time of discharge and follow-up has helped us to get these mothers to come frequently for follow-up to get their baby's jaundice assessed.
The only thing is TCB monitors are not available in all the centers, but even we do it, and we find it very useful. Yeah, we find it very useful. Thank you, Dr. Mangala Bharati.
Thank you, ma'am. Already most of the valid points have already been made. Just add 2 more points only. In the private sector, actually, one thing that seems to help is that in the era of early discharges, especially, a planned visit within 3 to 5 days of discharge seems to help a lot. Even though we are just teaching them and training them on many of the warning signs, because especially jaundice, dehydration, and feeding problems. So we picked up many times in the routine visit plan within 3 to 5 days. But in the government sector, especially public health settings with a lot of deliveries, though we understand the importance of home-based newborn care a lot, we should admit that the linking between tertiary care and the primary care is very weak, especially as far as normal newborn care is concerned. Though we have made some progress when we talk about high-risk babies or post-SNCU discharge babies for home-based follow-ups and all. This is a domain where I believe we need to work a lot and employ technology or other things. Right now, I will admit that we are very weak in the sector.
No, that is a point which I wanted to tell all the fellows here. See, please don't get worried that we are sending them and they are not coming back. There are 3 type of workers in the community: ASHA, Anganwadi worker, and an ANM, who could be linked. So if you care to look at their MCP cards, at least you will have 2 telephone numbers of the community worker with whom you can communicate and tell them we are discharging such a baby. This I don't want only for high risk baby, even for a normal healthy baby. Say that we have discharged and this baby is coming into your area, and kindly look after. These are the things which they would have got already trained, which we want you to go at home and visit. And if there is any problem, please let us know. We find that in our hospital, if when we are contacting them and telling them, if there is a problem, then they call back and ask us what to do, and they keep referring early if their child has some problem. So I think we should have some mechanism of linking primary care with the tertiary or secondary care. Unless that link is done, all these babies would come back to us with late onset sepsis or jaundice, severe jaundice requiring exchange and all other problems. I think that is one area we have to do. To reiterate the point which Mangala Bharati brought it out, we want early skin to skin contact at birth for at least 1 hour, which should be continued as much as possible. Early initiation of breastfeeding in the labor room with practical help, that is there. And also delaying weighing. This is one protocol based thing which we are not doing. We are urge is to go and weigh the baby, record it immediately. Weighing definitely after 1 hour, and injections after 1 hour. and routine suctioning to be stopped, and giving practical support to the mother for breastfeeding or any other problem, and linking it with the community is the most important thing I think we need to give. And of course, all our screening also helps us to detect early problems like eye, hearing, and metabolic problem, and all that should be part of the thing. Resource limitation should not be the thing. Already in RBSK, all these things have to be given as a guideline by the Indian government and Ministry of Health. So we should see to that all babies do get that, and it is their right. And those who are born so-called normal should not get into problem, and we should not lose them or have them allow them to have some morbidity. With that, I think again I want to thank NNF and Giri for giving me this opportunity. I'm really happy that we have spent almost 2 hours on management of a care of a normal newborn, which is uh, a rare setting. I really, really appreciate this initiative. Hope you continue to have good sessions onwards the whole of the year, and all the fellows benefit from these sessions. Thank you very much for this opportunity.
Thank you, ma'am. I think that was a wonderful panel discussion. A lot of learning points and very practical messages were given by our expert panelists. We enjoyed them. I hope the attendees also had a lot of points to take back home. Ma'am, there are some
We
questions.
have some questions.
Yes.
Some questions I did see in the pop-up. We can give the chance for the panelists to answer.
So,
somebody had asked how to monitor temperature in the postnatal ward. I think that question we can give to Sai. Has he left? Is he here?
Yeah, the first recording of temperature, it should be done within 1 hour. So that is important. And we have to train the mother and the family regarding the like how to assess the temperature of the baby by looking like comparing the center part of the body as well as peripheries. So how to identify the baby at an earlier stage, like in cold stress. So if there is difference in the temperature between center as well as periphery, that is cold stress. And if that cold stress is there, like they can check the temperature with thermometer. So we can train them, we can tell them like how, or they can escalate the issue to the postnatal nurse there, so she can check the temperature. So main thing is here, like they should know how to identify cold stress. So if they can identify, then they can bring to the notice of the healthcare personnel.
Okay, any other questions, Giri?
There was a question on temperature measurement over the mother during the golden hour, ma'am, which is the ideal way to measure the temperature of the baby on the mother.
That is what he answered just now. They can use, if it is going to be a nurse, to be using the thermometer, but for the mother to teach her on how to identify cold stress using human touch, where they have to do the central part, which could be abdomen or axilla, and then compare it with the periphery, especially the feet and the palm. He explained just.
Yes, ma'am. Some question related to cod milking and the ingredients, whether oil can be applied on the cod.
uh, we said we should not apply anything, not even oil in the cod, and milking only in situations where they have to take the baby for resuscitation immediately. Milking could add on to the placental transmission. Otherwise, if the baby is breathing well, even if it's a low birth weight preterm baby who's going to be sent with the mother, we can delay cord clamping at least 1 minute. 1 to 3 minutes is a recommended time for clamping the cord. And oil should not be applied on the cord. Yes. During the massage, the oil massage, see, though we talked about little about oil massage, generally people do not do it in the hospital. At least before discharge, they teach them how to apply oil, and most of the oil application or oil massage happens during the stay at home. So they should know how to do it from head to foot, and not to go around the umbilical area or over the stump. That is
Ma'am,
one advice here.
my question is,
Yeah.
any role of HMF or simil MCT oil to get vein weight
No, sir. For
in
a healthy term neonate, there is no role for HMF or MCT oil. That's what we have been telling. These babies are supposed to be normal, healthy babies. What we need to do is supporting their breastfeeding assessment, sir. Anytime somebody comes with weight loss, is the mother able to hold the baby properly? Is she giving adequate number of times? Is she comfortable? And what are the problems we have to assess physically? That is one thing which is lacking in the postnatal rounds. We just ask, are you feeding all right? Then we walk off. So if she says there is a problem or there is weight loss, we have to sit and assess if there is. And I don't think there is any role for HMF or MCT oil for a healthy term healthy infant, even if it's a preterm or low birth weight
thank you, ma'am.
infant, as long as. And another thing which really helps them is kangaroo mother care. Now WHO has recommended kangaroo mother care for babies less than 2500 grams and all babies less than 37 weeks. Earlier we were doing it for less than 1800. With the recent recommendation, those baby also become eligible for KMC. So if you do KMC along with adequate support for breastfeeding, their weight gain seems to be very good, and there may not be any need for your whatever HMF or MCT oil.
Thank you, ma'am.
Thank you, sir.
There's one more question, ma'am. How to address the concerns of mother who give a history of not getting enough milk?
That is a big session which you have to keep one day. And I suggest, Giri, you can call some of the mothers who had these issues, how a lactation support help them resolve this problem. There are so many reasons for mother thinking it could be a perception or it could be real. But we should not be judgmental and say that everything is fine, as Dr. Pradeep said. We have to do the assessment, sit with her, take the history, and assess what is the real root cause, and then help her. Then only we would be able. I feel any amount of talking for handling this session will not help, Dr. Giri. We should get in some of the mothers who really have become successful, who perceive that their milk was not adequate. Various mothers who are preterm, low birth weight, and those who had problem in the panel, who could be very vocal, and that would help rather than us talking about this.
Thank you, ma'am. I think there's comments by senior neonatologists that at this point of time, we are seeing most doctors have a low threshold for starting formulas rather than counseling the mother regarding the how to, feed her child. A more practical, demonstration is what is required. I think that is what been comments shared by the senior faculty. Thanks for the people who have shared their comments.
That is why I'm saying if we include mothers who have been successfully breastfeeding, that will go a long way in making these junior, our pediatricians and neonatologists understand that this is a problem which could be overcome and it is not just a myth alone.
Nice words, ma'am. Thank you. Just some closing remarks. I'd like to invite Karthik Nagesh, sir. Sir, are you there on the?
Yes,
Yes,
Giridhar.
yeah, sir.
Yeah.
Can you share your final expert comments and can give us some closing remarks, sir?
Thank you so much. It was wonderful hearing all the stalwarts in neonatology with pouring out their practical experiences. There are two things I want to point out, Giri, that you have been part of the writing group for the evidence-based guidelines on skin care for healthy newborns, which was published 2 years ago. And you've shared that in the comments also in the chat box. Please, I request all the young neonatologists to go through that. There are do's and don'ts for us to advise parents about what is to be done and what is not. It's all purely evidence based. And that is a good publication, probably the first ever publication in the country about normal newborn skin care. Also, as far as bathing is concerned, the swaddle immersion bathing technique is well now the most recommended way of bathing, and this has to be taught to parents before they take the baby home. And there's a guidelines in the same publication given for do's and don'ts for parents, which can be printed out by anybody and given to parents when the babies are going home. That's what we have been following for last about 2 years now. The other thing, which probably one small point which I want to address, and has happened fairly recently to some senior pediatricians' grandchildren, is the problem of transient tachypnea of the newborn in the delivery room and how to address that problem. This last about 20 years in Manipal Hospital, where I work in Bangalore, we have something called a transition nursery, where even after the baby is well and stable and the child develops any respiratory distress, we don't shift to the NICU. We usually know that these things take about 3 to 4 hours to settle down and transient tachypnea settles down. We may have to probably just deliver a little CPAP in the delivery room. And this has been found very useful and it reduces cost. And probably I'll have to later on ask many of you how you deal with this situation, but this has helped. And we therefore are able to get the baby back to the mother soon after the baby's respiratory distress settles down. I was talking to a younger colleague of mine recently who has finished a DM from JIPMER, where they usually give 40 minutes time for the distress to settle down and then they shift the baby to the NICU, which is probably a big burden on the NICU staff and the cost also. And we know this usually settles down. So probably a better extension would be to keep the babies in a transition area next to the labor room for about 4 hours maximum and then decide. And to this, we have added point of care lung ultrasound is available in most labor rooms now. And that tells us whether this is indeed TTNB and is likely to settle down. And this publication recently we did in February, which gives us a fairly good evidence that if the score of lung ultrasound is more than 5/18, the risk of respiratory distress is worsening, and probably we need to shift the baby to the NICU. So I would just add on to that, Girdhar. Apart from that, it's a brilliant presentations. Thank you so much for all the stalwarts giving their expert opinions. Thank you, Girdhar.
Thank you,
Sir,
sir.
one
Actually, to answer your point, sir, newborn stabilization unit is supposed to be there in all the medical colleges.
Oh,
As we
fantastic.
have the newborn delivery room resuscitation area, we should have newborn stabilization unit before you send the patients to NICU. So if you have in that area, then you can transfer the baby back to the mother very soon.
That's very nice, Dr. Kumada. Thank you.
now one question: any galactogog like papaya or lactotin have any role?
Sir,
Ma'am,
all the
please.
traditional food which the mother thinks is going to improve lactation, as a person supporting breastfeeding, we allow them to take, sir. The best part is allow the baby to suckle and see that the mother gets a support. That is wherein helps. If she thinks that's her galactogog, she can take it, sir. As long as nutritionally it is good, it is not going to harm to her. She can take.
Thank you, ma'am.
So I think we are running short of time. I think we are already 9:50 now. So I thank everyone for having stayed back. I think we had a maximum of 160 participants. We are still at 86 now. And it's very good to know that a lot of people have stayed back for the end of the lecture. That goes to, I mean, see about the quality of the stocks that expert has given us. So I think this series is going to continue. I think we have had a very interesting start. So every week on Thursdays, the timing will be intimated to the corresponding centers. We'll have further sessions from the NOEL team. So if there are any more comments, none are forthcoming, then I think we can close this session. I thank all the panelists. I thank Kumada ma'am, Pradeep sir, Mangalabardi sir, Naveen sir, Sai Kishore sir, and our senior faculty here, Dr. Karthik Nagesh sir, who gave us closing comments. Professor Srinivasan sir is there. Dr. Vijay Kumar sir is there. Padmapriya ma'am is there. And our entire team is sitting back here. I thank all people having sat back and for the start that we have given. Thank you all. Very good night. And stay safe. I think people from North, I think we are there with you. Our heart goes out to you all in your difficult times. I think stay safe. Thank you.
Good night, all of you. Dr.
Thank you.
Vijay Kumar
Thank
is
you,
the
Dr.
senior neonatologist.
Yes, sir. Vijay Kumar sir is there.
Thank you. Thank you, ma'am.
Thank you, ma'am, for
Thank you.
wonderful
Thank you, panelists.
taking of the proceedings, ma'am. So I'll we have recorded,
Thank you.
so
Thank you.
we'll put it up in the
Always a
group.
pleasure.
So thank you, Pradeep sir.
Okay,
Mangalabharati
thank
sir, thank you. And Sai sir, I think is just logged out. Thank you all. So we'll be disturbing you again and again, ma'am, for further sessions. Yourself also, sir.
Thank you.
Pradeep sir. Okay, yeah.
Thank
Good night to all. Thank you. Bye bye.